You know, a year ago, we were thinking that things were okay. We had heard about something happening, but we can't even imagine what has transpired over the past year. Um, we see some light at the end of the tunnel, but there's also fear in all of this that that light is an opening to the end of this, or could that be uh, a oncoming train as well? Um, and that is some of the questions. Those are some of the questions I want to address with our lab partners here from AEL, Poplar Healthcare, and UTHSC. I want to first and foremost thank Clint Cummings, who's been a great partner as the Medical Society has been in so many calls working through this pandemic, and also Mayor Strickland, who I have been working with for the past year, along with the Health Department and the Shelby County Health Department on this pandemic. So I'm going to share some slides, and Clint, I just want to make sure that you're able to see my slide sets. Clint, are you able to see them?
Yes, sorry about that.
Okay.
Yes, we're at the title slide now.
Okay, great. So I want to spend about 20 minutes or so and go over the science. And actually, I'll say this: it's changing so rapidly in almost day to day that I may miss some stuff that maybe some of you may know, and please feel free to put that up. So let's begin with the most basic curve that I look at nearly every morning. And I look at what is the daily number of cases. And as you can see, what happened since March is that we were seeing the number of cases, and on the right-hand side is the daily number of cases, absolute number, and on the left-hand side are per 100,000. And so we hit in mid-July, as you remember, the number of cases went up, and then again in December, November, December, very similar to the rest of the country. But what's really reassuring now is we're seeing a precipitous decline, and the number of daily cases have gone down. The epidemic curve is coming down for many reasons, but we'll take what we have and see what's ahead. What also is important to see is the number of hospitalizations. 300 hospital beds with COVID patients. Presently, we were as high as 600. So we can see that the hospitalizations have gone down, as has the number of ICU beds as well. So right now, less than 100 ICU beds are being occupied by COVID patients. We were as high as 150, 160. So all of this is very reassuring. The real question that comes up is, could there potentially be a third wave? You see the first wave, we've seen the second wave. Can we have a third wave? And the real concern at the national level is that certainly that is a possibility. And what is happening in Memphis and Shelby County, and how do we prepare for that third wave if it comes? But before we talk about the virus and the vaccines, let's look at the strain that we have right now and the other strains, mutant strains that are there. So the most basic slide that I shared with you before and with so many others is the infectivity and the mortality of COVID. And when we started off, we talked about how many people does one person infect. If we did no masking and distancing and we kept everything as usual, about 2 to 3 people would be infected. So run out of about 2.4. With all our effort, we have brought it down to less than 1. With measles, we know it's huge. It's 16 people that get infected. So what happens when a mutant strain comes and it moves the row knot towards the 3, 4, and higher? And that's what we are really concerned about. Also, the mortality. If you look at mortality with COVID, about 1.5% of those cases that have been identified are die. Now, we have other diseases like Ebola and MERS, which have a very high mortality. But what if a mutant strain comes and it has a higher mortality than the original wild type strain that we have seen? That is what we fear. And some of the mutations that are happening are bringing those two factors, increased transmissibility and increased mortality. So now I want to sort of walk through each one of the strains that is relevant and how they uh, how they respond, how they are in terms of transmission and mortality, as well as the vaccine. Not a very busy slide, but let's just walk through it step by step here. And I want to make sure that you're able to sort of put all of these different variants into a category in your mind to better understand, because there's so much media information. So let's begin with the first mutant strain that we've heard about, which is the UK one. It's called B117. And we do have one of that in Memphis. And it can also be identified in the PCR testing. So there are two types of tests that happen. Initially, it's the PCR test, and then there is the sequencing, which identifies the mutant strain as B117. When we see a S drop, which is a marker on the PCR, it gives a potential that it can be a B117. Doesn't always have to be, but it's a marker that it could be there. All right, when we look at the UK strain, in terms of transmission, what it does is it's 50% greater transmissibility. It moves your rho naught, notches that up to 0.5 more than what it was before. What does it do to mortality? Initially, we thought, the UK strain didn't increase mortality, but now we know that it can increase mortality as well, as much as 30%. Vaccine resistance, actually, all of the vaccines that we know about work fairly well against the UK strain. And so there we have protection from the vaccine. Then the question is a protection from reinfection. So does the wild type virus, if you get infected with that and you build antibodies, and then you are exposed to the UK strain, will you be protected? And the answer is yes, that there is protection from reinfection, which is not the case with the other ones. So the UK strain is probably the most worrisome, because almost everyone agrees that it is here in the United States in large numbers, and that it will spread very rapidly in our community by next month or 2 months. And it has led to close lockdowns in UK and London and other places. So that's the UK strain that's there. More transmissible, higher mortality, but our vaccines work against it. What about the South African? It's the B1351 variant. Now, all three, the South African, Brazilian P1 and P2, all have an E484K mutation. This mutation changes the virus in such a way that it gives it resistance against the vaccine, and also it leads to potential reinfection. So what do we know about the South African strain? That yes, there is greater transmission. And in terms of the mortality, we don't think that, or we don't know enough about that, the mortality, but the vaccine does protect us against severe disease, hospitalizations, or death. However, the vaccine is somewhat resistant, and also reinfection can occur with the South African strain. The Brazilian strain, there are two types. There is a P1, which occurred in the city of Manaus, and it was quite remarkable in reading in the Washington Post about this strain. Within 1 month, the entire city was inundated with cases of COVID, even though they felt that 70 to 80% of the population had COVID before. So very high level of transmission was occurring, and there was resistance from vaccine as well as reinfection. So the P1 is able to break through previous infection and has escaped um, mutation of the 484. Now, we have a Brazilian strain in Memphis, but it's not the P1, it's the P2. This is similar, that it also has the E484K mutation, in that there is resistance to the vaccine and reinfection can occur. However, it is not as highly transmissible. So I will summarize this very busy slide. The UK strain is more transmissible, higher mortality. We are most definitely seeing it in Memphis in America. This is going to become the predominant strain in the next 2 to 3 months. We're not seeing the South African in Memphis or Brazilian P1, but we have seen one case of the P2, and the worrisome part is that there is vaccine resistance and reinfection. We'll be going over this in looking at it from another perspective, but this sort of outlines broadly the various strains that we have. Now, here is looking, why was I so fearful of the UK strain? And it's because of this. When we looked at the UK strain, the B117, you can see the number of cases right now are very few. However, by March 23rd, not that long from now, 50% of the cases in US will be the B117 strain. It tells you how quickly this will take over as a predominant strain in our community. Now, here is, this is a bit complicated graph, but this will help you also see the impact that B117 is going to have. If you look at the different curves, this curve that I have my arrow on, the dark blue, is if we had the wild type and there was no mutant strain, we would be seeing the number of cases go down. And these are the number of daily cases per 100,000. And in fact, you add another zero, that would be what Shelby County is. Right now, we're seeing somewhere over here, we're seeing about 20 cases per 100,000 or 200 cases per million population. So we would be experiencing over this time, this decline. However, the B117 is climbing up, and it's going to lead to this gray area that we're going to see a decline, but then after March, there will be an increase again. And that is when we have no vaccination. And our rho naught is less than 1 or at 0.9. So what I'm saying essentially is that B117 is going to take us for a roller coaster ride and getting us into a third wave of by May timeframe. However, there is a difference from the previous two waves, and that is that we have a vaccine. So same curves. This is the same curve that we saw before, which was without the vaccine, we see the decline of the mutant strain, the increase of the variant strain, the B117, leading to a third wave. However, if we add the vaccinations that as they're going, what we notice is that that can sustain a decline to less than 10, or maybe that comes to about 100 cases or less in our county for duration into the summer. So vaccines really offer tremendous amount of hope. The key question is going to be, what percentage of the population needs to get vaccinated? And we'll talk about that in a little bit. But I think these graphs are from CDC, and they have done tremendous amount of research in looking at this. And this is very telling because this is what has happened in UK. So I put a lot of faith in these graphs as well. Let's go now conversation about the vaccine and what we know about the vaccines and the various types of vaccines. Very simply, this is the coronavirus. This is the spike protein, which is so often talked about and actually quite relevant. And here is the mRNA, and this is the part of the mRNA which codes for the spike protein. And in fact, that's what's used for the mRNA wrapped in a lipid layer, and that's what's in the vaccine. This is all from the New York Times, which has done a very good job of showing graphically what we need to do. And when the vaccine is injected in us, it goes into a vaccinated cell. Translation occurs, spike protein is produced, it's put on the outer layer, and then those spike proteins are seen by the antigen presenting cells, which make the T helper cells activated, and then B helper cells, and leads to the production of antibodies. And that's what protects us in the end when we are presented with a live virus. How effective is the vaccine? So I want to show you the data, which is from the EUA, from the Pfizer study. And what we see here are how many days after the first dose: 7 days, 14 days, 3 weeks, days after the first dose, that we can see that people were followed. Each dot and each square represents a positive case. So if you look at both the curves, were going together, meaning there was little or no protection up to the day 14. However, you can see a huge divergence in the placebo arm. This is on 20,000 individuals who had the placebo and 20,000 who had the Pfizer vaccine. Literally a huge bifurcation, and this represents the 95% efficacy. Only about 8 cases of COVID occurred in the vaccine group compared to over 160 cases. And if you look at it in this area, the 21 days, and you can see that bifurcation occurs after about 10 days from the first vaccine. So in short, you look at this curve, and I show this even to lay folks who have no medical background, and it's quite impressive, the impact of the vaccine. But there's not just one vaccine, there are lots of vaccines, and their efficacy and how they react to the variant is variable. So what we do know is the following vaccines have had clinical trials that have been reported: the Pfizer, which is the mRNA, and the Moderna, which we have available; AstraZeneca, which is available in UK and other parts of the world, and that uses an adenovirus platform to inoculate folks, as well as the Johnson & Johnson. And then there's also the Novavax, which uses a recombinant protein. In terms of efficacy for mild and moderate disease and severe disease, it's really important to separate those two out, especially because we are trying to prevent severe disease. Mild and moderate disease, for the most part, common cold, we can deal with this, and if people are protected, that's okay. So what we know, as you've all heard about, 95 to 94% efficacy is there. What is really important to know is that the efficacy of the AstraZeneca is variable, but for Johnson & Johnson, that's what I tell many people, for severe disease, the efficacy is over 85%. So that's really reassuring, as is the Novavax. Now, in terms of the number of doses, all of them require 2 doses. Johnson & Johnson requires 1 dose, and then there is question whether a second dose and their trials being done would bring its efficacy higher. And we've talked about this The UK variant, Pfizer and Moderna, for most other vaccines, it's not impacted for the UK variant. However, for the South African and the Brazilian variants, nearly all of the vaccines have a decrease in efficacy. Not to the point of being obsolete, but there's a decrease in efficacy. So just on this slide to say that we do have multiple options, and that different options, nearly all of them work against the UK strain, but all of them are challenged by the South African variant. And it really has to do with this E484 EEC mutation that occurs in the South African as well as the Brazilian. I hope that's helpful in putting the in perspective. What can we do? Yes, get vaccinated, but also I want to share a couple of slides on the impact of distancing and masking. That will have to continue until the cases have diminished sufficiently enough. And that has to do with, we know that distancing can protect us. This is an article in Lancet. Distancing 12.8% down to 2.6 if we went 1 meter distance. This is in terms of the transmission was declined. Wearing masks, for both people were wearing masks, and no one was wearing masks. Transmission declined from 17.4 to 3.1. Now, what is really interesting is the data that came out yesterday from CDC, and that's on the impact of masking and the types of masks that we need to wear, and that both people, both the source and the recipient, and if they wear. So let's look at that data and see does double masking work and how well it works. So if you have two people, the source and the receiver, and you have no mask on the source, the person who's coughing or talking and is infected, and you have a receiver, there is a 7.5% improvement in exposure. Now, I'll show you a slide what they mean by improvement in exposure. This was done on mannequins, and this was not a clinical study, but more rather a model study. So a very minimal benefit if the receiver is wearing a mask, but the person who has the virus is not wearing. However, if the person who has the virus is a source, has a mask on, there's a 41% improvement in exposure. However, it improves if we are doing various combinations of masking and double masking. So if there's no mask and there's a double mask and there's a double mask and there's a no mask, you get about 82% improvement in exposure. And lastly, this is where we've seen everyone talk. If you have a double mask and a double mask, there's a 96% improvement in exposure or reduction in exposure. What I mean by that is this is a bit complicated finding, but very similar and steady what was shown on the table before, where the gray lines are, this is when there is no masking, and then the others are somewhat masked, and the dark blue is when there was a double mask that were done. And what you, or excuse me, mask and mask, both people are masked. You can see that there is a dose response curve that's there, but also using tucked and knotted masks were equally good as double masking. So the key is fitting, not just having double masks. When I'm at the hospital, what I do is I put a N95, which I keep on there for the 4 hours that I'm going to be rounding, and then I always have a surgical mask on top. And then when I'm going into a COVID room and so forth, I'll remove the surgical mask and then place another surgical mask, not touching my N95. For the general public, what I'm saying to do is to use a surgical mask, and then on top of that, use a cloth mask or use a tucked surgical mask. And as we finish, I want to say, so we talked about when does this all end? Herd immunity is what we would like to achieve. With the wild type, it would be maybe 50, 60, 60%, at best 70% that would allow us to get herd immunity. But with the mutations, because the Rho naught, the transmissibility is so much higher, we're looking at 80 to 90% individuals will have to be vaccinated or become immune in order for us to achieve herd immunity like we have for measles and so forth. So with that, I want to pause, and we have multiple partners with us and have them talk about what they are doing in PCR testing, as well as sequencing of the variant strains, and to begin a conversation about that as well. From AEL, Dr. David Smalley, CEO, has a great partner. I'll have him speak, and then Jim Sweeney from Poplar Healthcare and Dr. Colleen Johnson. So David Smalley, if you want to add comments as to what AEL is doing and what you're doing in the testing arena for our physician colleagues.
I'll be glad to. First of all, in testing, we have had ongoing surveillance for some time, working with the University of Tennessee, and actually, Colleen will tell you that we've had samples being tested all the way back to April. But over the past couple of months, Dr. Jain has worked with us to do, between Poplar Health and us, over 100 samples per week in a surveillance type process. But in addition, any of the S drops that we see as we're testing are automatically referred also. Thank goodness we're having those situations work with Colleen Johnson. Dr. Johnson has been very good in testing for us. In addition, I will say our capabilities right now, we can do over 6,000 of those per day. So there's not a delay in getting those path processes in place and getting those results. Now, we look at those based on the individual results, and if we see something like that, report that to the health department, start contact tracing, and we certainly will reach out and let you know if there is a suspected case. One of the things that we will begin doing also by the first of the week will be testing for spike protein antibody, so you can look at individual vaccine, and we'll also have a combination test of both the antibody as well as the spike, so that you can look at those individuals to determine if they have immunity. We have in our preliminary results seen varying types of antibodies, and by the way, the spike protein antibody is a semi-quantitative, so you'll actually get a number, and those will vary. Typically, what we've seen after the first shot, a fairly good response, and after the second one, as you would expect with the anamnestic response, the titers go up substantially. So I'll stop there, Dr. Jain, but I hope we'll talk about some of the surveillance that we need to do and more mass.
Sure, absolutely. And Jim Sweeney from Poplar, would you like to add?
Sure. Thank you, Dr. Jain. I'll just add a little bit to what Dr. Smalley just said, because we're following a very similar protocol. We're all symptomatic testing in Shelby County is being run on thermo right now, so we can identify the S drop-offs. But I think what Poplar is trying to do, more importantly, in the next week, we're getting trained and set up with our sequencers to support Colleen and the county in being able to do more sequencing of not just S drop-offs, but with Dr. Jain and the county's help, identify areas where there are positive cases, and we want to begin doing a wider range of surveillance looking for the mutant strains. Okay.
Great.
Thank you.
Colleen, would you like to add?
Yeah, actually, I don't, I'm of course, running the sequencing, but I'd like to say that this has been a very, I don't know, exemplar approach towards working together at the local level to address the need for sequencing. As you know, the United States has been very behind compared to the world. We're somewhere behind Ethiopia last week. This week we are moving forward, and according to the network of spheres at CDC, we just reached 100,000 genomes across the United States. We've done at least 1,000 here in Memphis, and the real need for sequencing, though, is for it to be as real time as possible. So, for example, right now, the turnaround time at most commercial companies is about 14 to 18 days. And so that's going to be your window of opportunity in getting ahead of the curve. And I've been, over the last month or so, walking through why it takes so long. And I actually have a slide that I can share with you to kind of just go through this real quick. All right. So so this is everything that we do. And so there's a ton of different steps involved, and I'm just going to focus on kind of the pipeline on the technical side, and then some of the challenges that we face. It'll just take me a minute, so bear with me. So we get these swab samples in, and all of these need to be plated in these little, can you guys see my?
Yeah, you can
okay.
see your marker.
You see this little plate here? We have to get them all plated, and that's a manual step for us. The RNA extraction, of course, is automated for the most point. And then we take that RNA, and then we use 96 well plates to set up each sequencing reaction to create a cDNA. After we create the cDNA, we have to quantitate that cDNA to see the fidelity of our PCR reaction, actually. And so that involves a lot of primer sets that go into creating the PCR reaction. So each one of these steps, right, is a person or two that are moving this pipeline along. And so once we get our PCR products, then we can actually create our library, which is what we sequence, and using this next generation sequencing technology. And then that is what is put on a machine called, there's MiSeq, there's MinION. We've used both. And that in itself can take about 18 hours. And then, of course, when we're done with that, then we begin to actually do all of our sequence gazing. And the challenges over the past 2 months that we've been facing is that the supply chain is broken. And so it's very difficult to keep a lot of the supplies. For example, if you purchase Arctic primers from one of the companies, it can take 2 to 3 weeks for them to come in. And so we've done quite a bit of work with David Smalley and AEL, and we know that with the primers that we've designed, we get better sensitivity than the Arctic primers, but it's taking so long to get our own primers. We're using the Arctic primers, but what you see here is the CT value, and so this is very low detected material. But we're still able to pull out SARS-CoV full-length genomes, and so this is kind of like just a little snapshot of flavor to give you this many step process, and then you get to the bioinformatics, and then you get all excited like I did today, and I sent the wrong number to these guys are the patients. Yeah. But It's a very involved process. But if we can get in Memphis, if we can think locally, what we have here is an amazing network to move very quickly. And I think our turnaround time will be half of what is at the state, national, or commercial level. I really do.
Yeah, absolutely. And I would say that, we're very lucky to have Colleen, you and UT's lab to move these things along, as well as AEL and Poplar to be on top of things. It's rare in a city to have such a collaboration between the clinicians, as well as the labs, as well as the health department, and so forth. So I'll look at some of the questions, and Clint, if you can, have others also ask questions. But there was a question about how do we explain the vaccine resistance, yet a vaccine protects against severe disease? Are these theoretical or clinically proven? So actually, the answer is both. So for the Moderna and the Pfizer vaccine, in terms of their impact for the South African variant, as you know, when those studies were being done, the South African variant wasn't there, so we don't know what the clinical findings of that would be. What they found was there was a 1 to 1.5 fold decrease in the antibody for the Pfizer, and about a 6-fold decrease in antibody for Moderna for the South African strain. And then when you look at the other vaccines, which are the Johnson & Johnson, the Novavax, we do have clinical data on them. And there was a 60% efficacy against the South African variant. So not the 90 plus efficacy. But 60% is okay. And like we've talked about, and as you said in your question, it works against the severe disease, and that's really what we're trying to protect against. The second question was, why should persons wearing 2 masks not be more likely to breathe around their 2 masks rather than breathe through the 2 masks? So absolutely, if you're wearing 2 masks and you're still not getting a tight fit, you're not getting the benefit of the increase of transmission of the virus, or increased protection. So the key is not 2 masks or 5 masks. The key is the fit. And even if you can do 1 mask with a knot and a tight fit, that's really what will work the best. So really important to keep that in mind, and do the whichever mask you use, make sure that you have a tight fit. The question on, are vaccine manufacturers working on booster for the Brazilian variants? So the manufacturers are actually working on all of the variants, and it is very likely that we will have a multivalent vaccine soon, by the fall. And that's really important to keep in mind, that we're not looking at now just one vaccine, but a multivalent vaccine. And likely we're not looking at just one time, but like the flu, not maybe every year, but more often. The way the epidemic is going to end is that if you can stop the circulation of the virus, and the mutations will end if you can stop the circulation of the virus. That's the most critical step. If the virus continues to circulate, it continues to mutate. That's where we have to really double down on the vaccinations, distancing, and masking to make the difference. There was a question from CDC's new recommendation to advise Americans to select masks with a nose wire that can be adjusted for a snug fit, and to use a mask fitter or brace to better seal their mask. So again, fitting is the key. The CDC also recommends wearing a mask with multiple layers and greater protection. Yeah. So all of those are really important. It says it does not recommend wearing 2 disposable masks at a time. and it says there's no need to layer another mask with a KN95 mask, right? So that's generally for the general public, there's no need to be doing that.
So I received another question kind of along the same lines that I think people are generally confused about. And I think this call, we probably have a fair amount of vaccinated people on this call, right? So Dr. Jain, if you and I are the only two people in the room and we're both vaccinated, what are we supposed to do then? Are we safe to just party like it's 2019 or?
So good question. We don't have an official answer to that, but I can give you a hint towards what the answer will be. So it really has to do with the question of transmissibility. So the questions that the AstraZeneca and Moderna vaccine did not answer was, are they less transmissible? We know that, yes, they decreased the disease, but were they less transmissible? What we do know about AstraZeneca is that it was less transmissible, that if you had vaccination, you did not get transmit as much. A preliminary study, not published quite yet, from Moderna also found that it decreased transmission. Once we begin to see those studies, Clint, you and I can party like it was 1999.
Or any other year besides 2020 for that matter, hopefully.
So I think that's what's going to make a difference. Now, all of this plays into the variant strain as well, which can change things. But short of that, then yes.
So we've received a lot of emails and a couple of questions tonight related to second doses. So the health department's releasing second doses and they're selling like hotcakes, or not selling, but they're going like hotcakes. I think the CDC guidance is 42 days is still okay, up to 42 days, but will you clarify that for everybody? So if I miss my, ideal 19 to 23 day window for Pfizer,
not a big deal. You're absolutely okay. And this is actually, everyone from my wife's parents to my relatives, uncles and aunts, and close friends, they're freaking out because they did not get the second vaccine on day 21 with Pfizer or day 28. Honestly, that is not anything to really worry about or be concerned about. I tell people that there will be sufficient vaccine, and if you get it within 3 months, not a big deal. The only reason that the 21 days in large part, I think, was chosen was because Pfizer and Moderna wanted to get the study done sooner to show the efficacy. But with hepatitis A, we wait 6 months. It's not a big deal. So the way I message it is to say, listen, after 21 days, after 28 days, there's no hurry to get it right at the 21st day or the 28th day. It's very safe to get it afterwards, and that will have a good response.
So a couple of questions just about, I guess, vaccination priority. This one is one that I've heard before that was asked on this call as well. I know that there's no official category for families of healthcare providers, but if you are a healthcare provider, you probably think there needs to be one. Can you give any guidance on that?
So we're talking about different phases. And as you know, teachers and families of health providers or families of patients at St. Jude's or families of patients who are individuals who are disabled. So those are all very challenging questions. What the health department and at the state has done is develop those phases. We at Shelby County with the health department here has taken those to be the guidelines. Some people say, for example, some counties like Nashville have decided that they were going to have the teachers be way up front, and that's been because of different priorities. So what I would say is you can go on the state website or the Shelby County website, look at where the 1A1 is, 1B is, 1C is, and where people land up. I would say we have stuck with this, what the state is doing, just to be consistent to a great extent. There was another question: why would such an aggressive variant occur in South Africa, where presumably there may be less vaccine available than in the US? So honestly, where these variants occur is just random. It's Russian roulette as to where it's going to happen. What we do know is that there are 1 or 2 significant variants occurring every month with COVID-19. And that's what's important to keep in mind, that there's so many variants that are happening that that it's only the significant ones, the ones that have increased mortality and increased transmissibility, that we hear about. And most of the mutations are useless and the virus dies out. But those are the ones that really become the prominent ones as the virus evolves. Are patients who have had COVID more than 2 weeks ago still transmissible? I think the public needs education that they still need to use masks. I think the public thinks they don't transmit after 2 weeks. So let's talk a little bit about isolation and quarantine. If you have COVID or a patient has COVID, they are asked to be in isolation. That's the word that's used for them for 10 days. And they can come out of that isolation after the 10 days if their symptoms are better for 24 hours and they're symptomless, they're feeling better, and generally things are improving. There's no need for them to get tested. Why? Because multiple clinical studies have been done that after the 10 days, the chances of transmission is very low. You're at about 5 or 2% or less. There is a minor chance, but very, very low. If someone is been exposed, then they are in quarantine, that they don't have symptoms yet, or they may not have turned positive, and they need to be in quarantine for 14 days, because that's the incubation period, and that's what you have to basically wait for. So the answer is the masks and all, we should be all wearing it at all the times, but being in isolation, quarantine, 10 days, and then the 14 days. There is a way of getting out of quarantine early. Instead of the 14 days, you can do it 10 days if you do a test after around the 10th day. And then if that's negative, then you can be out of quarantine early. But generally, that's the rule that we have for isolation and quarantine.
So there's a couple of comments in the Q&A section that are kind of a follow-up to that question around, I'll try to ask it simply.
Please.
How does vaccination change isolation and quarantine?
Yeah. So, and this is what I will say, it changes very quickly. Is just today, I haven't read the guidelines and the details, but the CDC has put some details on people who have been vaccinated and then they have exposure, then they do not need to be in quarantine. The details of that I haven't looked through yet, but vaccination will allow you to not be in quarantine. So that's, I believe that's 14 days after you have been vaccinated, up to 3 months. Don't know why they made that 3-month limit. If you have a close contact and you've been vaccinated, you will not need to be in quarantine. So that's something which just came out recently.
And I've pasted that link into the chat from the CDC site.
Great.
Next one is asking you to comment on breakthrough cases in vaccinated individuals and how does vaccination affect the molecular diagnosis of disease?
So very good question. So let's talk about, and actually I'll have the labs also give their thoughts on this. So when you have a clinical case that you suspect, someone coming from South Africa, someone coming from UK, what you really need to do is to have those to be alert the lab to be tested on, if they've come from UK, to look for the S drop. And so we look for the UK strain B117, and also to look for and to do sequencing on them if they are potentially high risk. Also, if they've been vaccinated, because we know that there is vaccine resistance and there could be new mutations that are occurring, we can look at those mutations as well and determine if there's resistance. So if you have any suspicious case, let the labs know, and we will have that sent to Colleen's lab at UT, and Poplar is also starting to do sequencing, and we will have much more information. I'll ask if Colleen or Dr. Patel or Dr. Smalley want to add anything to how we should be thinking about testing for those who are high risk or potentially have the vaccine and then have occurrence of COVID.
Well, I mean, those are your high priority ones for sequencing. And it takes some time to sort through and understand if it's not a novel, if it's not one of these variants of concerns, then one has to look at the molecular interactions to try to understand where the breakthrough occurred and if it's real or not. And so you would expect to see, for example, something in they call it the RBD domain. That could be a site where you break through. And so once we start getting that sort of activity, that's going to really, you're going to really want to dig into that quickly.
What Colleen is talking about is the receptor binding domain, and if there are mutations in that, that's where it changes the vaccine as well as the reinfection risk factors that come in. David, would you want to add something?
Yeah. If in fact you see situations where we need to be looking for a possibility of the UK strain, if you let us know that it needs to be tested by the thermo, we'll make sure it is. We're testing now about 60% of our patients by thermo anyway, but again, just remember that some of these do not have the S drop, like the South African and so forth. So the first step is clearly looking at the PCR. If it's positive, then moving on to sequencing. So, you know, again, communication helps us a lot in driving those tests.
Great. There's a question on, do we really know how long vaccine immunity lasts at this point? Is it different than post-COVID immunity? So we don't know, but at least some of the clinical information at even COVID immunity, 5 to 6 months, vaccine immunity, similar amounts of time. We will know, obviously, as we get more data over time. But in all honesty, what we need to do is to get the virus out of community transmission into cluster outbreaks to individual outbreak. When it happens in community transmission, that's where we get into trouble. And the more people we get vaccinated, I think that's going to be key.
If I can jump in on that
Please.
also, given the fact that we've had a couple of these different variants in the Memphis area, again, we've had situations where someone had been in with some type of symptoms, but they've had the typical type of allergies and so forth, they still need to be tested, particularly within the zip codes where we have identified these types of variants. So please test so that we can pick these things up. The sooner we identify those, then contact tracing can be done and we can squelch this. But if those patients are not tested, then we won't know until it explodes on us.
Absolutely, and it's going to become imperative that as we go, a year, 2 years, 3 years down the line, that the first responders, the primary care doctors, and others are going to have to be very alert in getting this tests done very quickly. And we have lots of office tests available as well now, the rapid tests. So those adds a multitudes of options. Just be sure to know the limitations. One of which is if you get a negative on a test, which is a rapid test, that's not the definitive answer. If you're expecting something else, we know that there are a large number of false negatives, false positives with those tests. Yeah.
You can take the one in the chat if you want. We have 2 or 3 left in the Q&A.
Okay, so thoughts on patients with multiple negative tests while symptomatic who later test positive for antibodies. Why aren't our tests picking them up? Very good question. And in fact, what is happening is likely that they were PCR positive, then turned antibody positive, and they became PCR subsequently negative, not actively shedding the virus. And where we see the complications of COVID is in that immune phase, the cytokine storm, which is about 2 to 4 weeks down the line from their initial infection. So that initial 8 or 10 days, we haven't seen when they were viremic and likely infectious, that they were not seen. David?
Can I add one? Yeah. One of the things that we have seen, particularly with individuals where they come in to see their provider and they've done nasal washings and things like that before the specimens are actually being collected. And if they're taking some type of medication, it can decrease the amount of virus that is being detected. So I would caution people not to actually try to clear their sinuses before they actually get examined, because that's going to decrease the possibility of getting picking up the RNA. So I would suspect that viral shedding actually has some variations through the day and night and so forth also. And so if you get repeated negatives and then get a positive, it probably is sampling as a possibility also.
So that gets into the next question, which Dr. Kirkland asked was, as an ENT physician, I seriously doubt that very many nasopharyngeal samples are actually taken. Do you think anterior to mid nasal cavity specimens are just as good? So in fact, the IDSA website, Infectious Disease Society website, and multiple other websites have several references to this. And what they've talked about is that there's a pretty good 90 to 95% sensitivity, specificity for the mid-turbinates and the anterior nares. And so for the large part, when we're doing sampling of asymptomatic people, and this is large scale surveillance, we're doing anterior nares when there is a specimen being taken for the symptomatic individuals. Mid-turbinate actually is really good. I don't think there's a real need for a deep nasopharyngeal swab, but mid-turbinate is probably the best one.
So 2 or 3 more that should be pretty quick answers here in the Q&A.
Yeah.
Are immunoglobulins immunocompromised patients, excuse me, able to produce enough antibody T cell response to the vaccine?
Answer is we don't know. I really wanted to find out we saw the Pfizer curve, and you saw 8 or 10 people still get COVID after they had the vaccine. Were they immunocompromised? Was it elderly? Was it why did they not why were they not protected? And did they have a T cell response or not? In fact, we can begin to now measure some of these things, and we'll know more information. So it's unclear why certain people have failed the vaccine. And being immunocompromised, as we know, in many other diseases is probably the most common reason. And I would suspect that is a cause. And I wouldn't be surprised if soon they may be asked to get antibodies and T cells checked and receive another vaccine booster after the 2 doses.
What is the guidance for folks who have had COVID and when they should be vaccinated? What time period should elapse there?
Right. So the CDC hasn't had a clear guidance on number of days. I can tell you what I'm telling my patients, which is wait about 30 days after you've had COVID, and wait 90 days if you received monoclonal antibodies to get a vaccine. So generally, that's the guidance, but do get the vaccine.
And the last one that I see is, where is the biggest delay in vaccinating? Production, local distribution, or both, or something else?
Right. So I will say this: the health department and a lot of the folks who are the hospitals and others who are pharmacies who are doing the distribution are really bearing the brunt of, can't get the vaccine and can't get scheduled. The real problem is at the state and the federal level in being able to bring the vaccine to the sites. We just don't have enough vaccine. We get about 10 to 15,000 doses per week and have to distribute them between all of the hospitals and the health department, do the first and the second dosing, and it's just not enough. However, that's going to change. And this is what I am convinced of, that within the next couple of months, especially with Johnson & Johnson coming out with potential AstraZeneca, but also the Novavax being available in hundreds of millions of doses, we will have a vaccine surplus. It's going to be, demand is not going to be able to be keep up with the supply. The supply will be high, demand will be low. And honestly, that is where we need to be thinking about, which is, how do we hardwire our society into getting the vaccine? What I mean by that is, if we do what we're doing before with the public health messages and PSAs and all that, with the flu virus, influenza, we only get about 50% of adults vaccinated. That's horrible. Now we're talking about, with this, maybe we can get 60%. We're getting nowhere close to herd immunity. We've got to be getting to childhood immunization levels, 80 to 90%, if we want to do this. Mandate or no mandate, we can't do right now because the EUA, emergency use authorization, is in effect for these. They have to be first approved by the FDA, but then obviously we know all of the implications that go into making something mandatory in our society. So as healthcare providers, as doctors, really think about all the implications that go into hardwiring, really think about hardwiring vaccinations so that we can collectively be safer. So I'll pause with that. Thank you so much, everyone, for your time. Lots of great questions and lots of information that's still evolving and changing. And please feel free to connect with Clint. He is fabulous in conveying information. He's on dozens of our calls and takes the information and brings what the provider needs are. And this was a provider need to be talking about the vaccine and the variant. And obviously we're seeing it in our community and how much it's impacting us and what we need to be doing. So thanks so much, and please take care and be safe.
Yeah, I'll just tell everybody, if there are other topics or things you want to hear more about, feel free to send us an email. We'll be glad to cover other things. Thanks, Dr. Jain. Thank you, Colleen, Dr. Smalley, Dr. Patel, and Jim Sweeney for joining us. And we'll see y'all soon. Stay safe and stay resilient.
Okay, bye-bye.